Fine. All right, well, we'll do take two. Good evening, everybody. You can all say it along with me this time. So welcome to tonight's Health and Wellbeing Board meeting. My name is Councillor Alex Anderson. I'm the Deputy Leader and I will be chairing the meeting this evening. Before I start, we've got the standard housekeeping points. The meeting is being live streamed to the Council's YouTube channel. So participating, you are consenting to being recorded. Please can officers and guests introduce themselves when they first address the committee, and if the fire alarm sounds, please leave the meeting in an orderly fashion by the staff fire exit, which is behind me to my right. Officers will direct you to the assembly point in Riverside Gardens. Thank you very much. All right, apologies for absence. We have a number of apologies this evening. So we've got Councillor Bora Kwan, Councillor Helen Rowbottom. We have, assorted officers who we're going to be covering for this evening. We've got DI Khan here for DCI Staples, so we're going to make do with the dream team that we've got here this evening. Any others that I need to note that I haven't listed?
Sorry, Councillor. I just wonder if the minutes could be noted that Catherine Wilmot is not the interim Director of Adult Social Services. She is permanent. Thank you.
Thank you. Good spot. Right, declarations of interest. Do members of the board have any declarations of interest? That might just be us. I don't think I do. Do you? Great, lovely. Minutes and actions. Any comments or questions about the minutes of the meeting held on the 11th of December? And are there any actions outstanding? No, great, lovely. And are the minutes agreed? Agreed, lovely, thank you. All right. So our first substantive item, Peter, over to you for the special, for the SEND SEF, please.
Thank you, Councillor. I'll do take two as well. So I'm just here to report in on some of the progress with our Hammersmith and Fulham local area SEN SEF. I use the term local area very carefully because it's not just about the local authority, it's about all of our stakeholders and all of our partners who play a very key role in our self-evaluation form. I believe I came previously with colleagues from health to speak at this board about some of the work and progress that we were doing around SEN and around outcomes for young people. So this is a report back in terms of some of the progress that we're making on specific areas. The SEF focuses in on three really key questions, which are in the summary there. So just quickly go through a couple of key points. Firstly, what do we know about the impacts of our arrangements for children? How do you know what our impacts or arrangements for children is having? And what are the plans for the next 12 months? So it's very much focused on our young people. It's very much focused on impacts. If you look through the paper, there's a couple of kind of key things that I'd highlight. So firstly, the key with our SEF is it's a true reflection of the areas for development and strengths across our local area partnership. So as I was saying, that includes colleagues from health, colleagues from social care, and also from education and SEND. We have really strong governance within the team, and the SEF goes through our SEND delivery group and then to the Children's Health Education and Social Care Partnership, or CHESC, which provides really kind of detailed and rigorous senior oversight of what we are doing. The SEF is links very much to our SEND strategy, which is co-produced or was co-produced, with all of our partners, and obviously can be found on the council website and gives a really clear indication of our direction of travel. We then move into the kind of main section of the SEF, which is around outcomes and focus. This looks at some of the key things that are working really well for the council at the moment, and a couple of areas which we need to continue to work on, improve and develop. So firstly, for example, you can see there the performance of some of the health visitors and new birth visits, etc. The fact that all of our schools are good or outstanding, judged by Ofsted, which is really positive, and we have great outcomes for children in terms of our education outcomes. Where we look at our EHCP plans, for example, nationally about 50% of those are completed within 20 weeks, but last year we achieved 85%, which is really positive. We work very closely with our commissioned alternative provision providers, lots of work going on at the moment in terms of transitions and the work between children's services and adult social care to ensure that we've got really positive work there. And one area of development, which we're kind of very much closely working with colleagues in health, is around our autism waiting times, where we've had significant increase in additional funding to support with that and the development of a while you wait offer. The second section focuses in on children and young people. Rather than going through this section, I've got a short PowerPoint that I'll just ping up for you, hopefully, David, if that's okay, which looks very much more on what the children themselves have said, which I think in the long run is what's most important. Now, we've been doing some work over the last, well, since the beginning of this annual year, looking really closely at our work with children and young people and getting their voice on the work that we're doing. So we've done a number of different focus groups with young people with SEND and EHCPs as well. And this is very much focused on our outcomes framework, which I'll explain in a second. We've had a number of kind of themed meetings with colleagues from housing, colleagues from supported employment, with both our parent carer forum and children's and young people as well. We've got a number of reflective sessions linked in with young people, specifically around the employment pathway, and a lot of community engagement hosted through our family hubs, as well as sort of surveys and other bits and pieces. This has led us to be able to assess how we're doing against our outcomes framework, which you can see on the next slide. So the 5 key outcomes, and just to stress here, these were very much defined by the young people themselves, is that my voice is heard, valued and acted upon. I am able to learn. I feel happy and enjoy good health and well-being. I feel safe, supported and part of my local community. I am in control of my life. So that's the 5 outcomes that they are looking for in terms of our progress in terms of SEND. And what we've been doing especially over the last 3 months, is collecting kind of data and information against those 5 outcomes, which we can see on the next slide. So for example, here, you can see that we're looking against the valued heard. It talks about how they feel valued at school, how they feel heard and listened to by the staff that they work with. And then where we can look at some developments, etc. We've got actions which we've been focused in and working on. So for example, our youth council is very inclusive and takes on views and viewpoints from various different young people, and we've implemented some new and different teams, not in the last 3 months, but over the last couple of years, to support young people around communication and things like that. Where we've looked in on being able to learn, that again, we've taken feedback from the young people, linked it to some of our actions that sit within the SEF and looked at how those can be developed. And finally, on this slide, we've got probably one of them, well, they're all important, but I feel happy and enjoy good health. That links into sessions, for example, where young people have been to CAMS and have said that's helped them a lot. They've had some help or need some help to regulate their emotions. So we'll look at that and how we can develop that. So it's very much about linking the young person's voice and all of those sorts of things to the outcomes that we're trying to enable them to achieve. The final 2 bits, I won't go through these because I'm conscious of time, but they obviously link into the final 2 outcomes, which are around feeling safe and being in control of their life. And that's very much around things like looking at developing an independent travel training module through working with Wood Lane, looking at how we can make sure that our local offer pages are really clear in terms of the direction of travel around preparation for adulthood, listening to the young people about the types of resources they like to access rather than the ones which their parents might want, and looking at how we adapt those and go from there. So I thought that was sort of more valuable really than going through the kind of report in verbatim in terms of children feeling valued, visible and included. The final thing that I wanted just to say, just towards the end of the report, is around leadership, governance and accountability, which is obviously really key for us and forms very much sort of half of the SEND framework. And we know within this that we have really strong commitment and engagement from partners. That includes parents and carers across the SEND system, and we've developed a wide range of effective governance and arrangements that enable us to kind of really focus in on our strategic decision making and service delivery. So we feel like this is a strong area for us, and it's something obviously we're always looking to adapt and take feedback and kind of move through. But in general, we're seeing some really robust and positive work against our SEF, with the proviso obviously that we're always looking to hear from people and develop and improve. So that's all I really wanted to say, linked to the paper. So happy to take questions from anyone here.
Wonderful. Thank you very much. Do you want to say a little bit about the award that we've just won for how brilliant our online service is?
Yeah, so our online service came back into the council 3 years ago or 4 years ago. I think it's fair to say that there was a little bit of work that was required. A lot of that work was done with families and parents and carers. And we've actually been awarded an award from the national, it's called NAFIS, the Information Service, as the best local offer in the country, just in December this year. So we're very pleased with that. It was very much focused on how it had been developed, as well as what is on the system, because through the family hubs and the co-production work that we've done, it was very much focused in on what parents and young people wanted to be able to see and the developments they wanted from us. So it was very pleasing. Thank you, Councillor.
Thank you and congratulations. I think that really speaks to the approach of SEND here. It's really brilliant. Thank you. Any questions on that? Great. Well, I think that's provided all the information that anyone needs. Thank you very much, Peter, and thank you for the brilliant work. And
thank you. Cheers. Thanks, everyone.
very nice to see you. Thank you. Right. Very cheery, slightly less cheery this one. Nikki, over to you.
Thank you. I'm Nikki Lang, Director of Public Health for Hammersmith and Fulham. We are bringing tonight the suicide prevention strategy to the Health and Wellbeing Board. It's a requirement for every council to have a suicide prevention strategy. We've divided it into 3 different sections. So it's see, say, signpost. In terms of the key data, you can see on page 21 our suicide rate, which at the moment is the highest in London, which is why we've done so much work to remedy that. On page 22, you can see the risk profile. So it's white males aged around an average age of 41 at death. And at the bottom of page 22, what's really interesting and which has formed the basis for all of our work for the last few years are other risk factors. So they include substance misuse and mental illness. Going on to the say section, so on page 26, we have the main objectives of our strategy outlined there. And then moving on towards signpost, we've done a lot of work with partners. So thank you to everyone who sits on the suicide case review group and also the strategy group. We've worked on discharge packs. I know that Healthwatch will be speaking later. We worked on discharge packs for mental health patients being discharged, and also refined our bereavement offer with thanks to the police who give us very excellent help on suicide prevention. And we've had a communications campaign which was launched in September of last year. So we commend the strategy to the board for sign off and thank everyone who has played a part in its creation.
Thank you very much, Nikki. This is, I think, the final stop on the journey for this paper, so it's been well versed and fed into across the council. Obviously, every life lost to suicide is a tragedy, and thank you to you and your team for taking this so seriously and working to produce such a broad-thinking report. Any questions on this? Yes, Councillor Perez.
Thank you very much. Thank you, Nikki, and also just to echo Councillor Sanson, thank you for the strategy and how you've plans in place. Can you please tell us a little bit more about the multi-agency partnership approach? So what are those agencies and how do we work together with those agencies to provide the service? Thank you.
So we have a lot of systems, but I should say, again, with thanks to the police, we now do real-time suicide surveillance. So it's called RTSS. So every time an unexplained death happens, we're immediately notified by police colleagues. We then check whether the sad death was known to mental health service or substance misuse service. So we do an immediate check around. In terms of multi-agency working, we have set up 2 main boards. So one is a suicide case review group, and we have relevant partners on that group who include adult social care, mental health services, and others who have drug and alcohol services and housing, who have a read across to those cases is confidential. Everything is sort of protected in that way. And we try to take immediate learning by reviewing the cases in tranches, so that we can glean information about the risk factors they had and what we need to immediately change about our practice. The other group we have was the suicide prevention strategy group to create the strategy. And again, multi-agency partners, including criminal justice and mental health partners, and also the VCS and Health Watch.
Thank you. Nadia. And Nadia, do you just want to say who you are and where you're from?
Present Health Watch this evening. I'm the chair of the local committee. I've been part of this board for a number of years now, but it wasn't until this time last year when we had the previous suicide sort of report, if you like, that I found out that our borough has the highest number of suicides. I did question last year whether there was anything the local authority could do, obviously in partnership with other agencies and other partners. And it is quite surprising, I must say. We obviously had a very detailed report, so thank you very much for that in our paperwork. But I did want to ask you, if that's okay, if you could provide a brief summary of the strategies that have taken place, the actions that have taken place to actually, reduce that number, which still remains not just the highest, but very high, but also the highest in London. It is quite worrying. And last year, I remember questioning as to what we thought collectively might have been the reasons for that. What is it particularly pertinent to our borough that actually places us in that statistic? Is it sort of the fact that, we have more tube stations or bridges or, whatever people use as that's being very sort of, I don't mean that in any disrespectful way, but it's actually quite worrying as to what it is about Hammersmith and Fulham that has that dark statistic. So if you can tell us a little bit more about what has been done, and I appreciate the numbers haven't reduced. We're still the borough with the highest number, but what has been done? Because I'm particularly very proud of the suicide prevention event that we had in September, where although the numbers were quite small, we were, I felt, able to touch some lives and hopefully make a difference with our own intervention of the Health Watch. But on a larger scale, on a more important scale, what has the borough done and the public health and the ICB, all the partners working together, what have we been able to do to reduce the number of suicides in the borough? Sorry if that was the
that's
rather
fine.
long-winded way of asking my question.
That's fine. I suppose the quick answer to that is to develop the strategy, and that's the whole point of bringing it all together so working with all the partner agencies. I think we do need to be careful to not conflate living with Hammersmith and Fulham with necessarily resulting in a higher risk of suicide. I think we don't know that, we can't prove that. Obviously, there are myriad reasons as to why people feel driven to suicide. I wouldn't want to send out a message that living in the W6, W12, SW6 postcode is likely to mean that you have a higher rate. I think particularly given we know things are much more complex post-COVID as well, I think there are lots of reasons, and that's one of the things that we're working to understand. The data, there's a bit of a lag in data as well, so we don't know technically if we still have that highest rate. That's one of the things we're obviously keeping an eye on, and it's continuing to work with partner agencies, recognising that it is everybody's business to work together. The event was very good. I attended that one. Lots of agencies there, and they're again ones that we've worked with to draw the strategy together. Having looked at lots of the others from other boroughs, I would say this is a much more comprehensive strategy than I've seen in from lots of other places. So I hope that's the reassurance that we are taking this very seriously. Is there anything that you want to add, Nikki? And then James, I'm going to come on to Dr. Kavanagh, I'm going to come on to you as well. And
it was
yeah, I
more
can't.
actually sort of taking in rather than questioning, what has been done. It was more about
Sure.
Because it is very much like common, joint responsibility. I feel. Just to make
Sure.
I wasn't being critical. I was just inquiring.
I'm happy to take that. So in terms of why do we have a suicide rate, those are the factors that we have on that page. As Councillor Sanderson said, these are incredibly sensitive statistics. I know whichever group I go to, people want to say, well, if only you did this. These are really small numbers. We may have a risk factor that pertains to one death, but we have taken action on that factor. So we've presented the data before and shown that 50% of our completed suicides are in mental health patients. So a lot of our work is around working with the mental health trusts, and I'm sure Carly can attest to that. The other risk factors or unique factors in deaths, we have addressed them all. So we can't list them because you may know that person and we don't want to cause distress. But be assured that every single risk factor that every person who's died had, we have worked on, be it immigration, drug and alcohol issues, the list goes on, divorce, financial issues. So we can't list them because that would be hurtful to people, but we have done extensive work. Thank you.
I just thought I'd raise it. On the health side, we've put a lot of investment into encouraging PCNs to do proactive reviews of patients with severe mental illness and what we call continuing chronic mental illness, be that depression, personality disorder, schizophrenia. And we have a good level of interaction with services, which I think are crucial in these cases, such as Turning Point. We have people who have dependency issues. We have an excellent Turning Point and dependency team in the community in Hammersmith and Fulham. So on the health side of things, there is a lot of investment going in to try and proactively recognize people who have the risk factors that would lead them to suicide. And then we also are involved in the case reports following any suicide. And we encourage our practices to engage with those so that the learning can be shared back into health as well as into other providers.
Thank you. Nadia, I just wanted to kind of just give you some figures that we've got, because we touched on this last time, and I remember I've got some figures here for only 6 months of suicide and attempted suicide reported to the police. And out of those, 14 incidents in the home address. So I don't know.
Describe actually wasn't asking for the particulars of each case, it was more about patterns. When I asked previously, I wasn't seeking, particular details for each case. So there's no, obviously I understand confidentiality, I understand sensitivities. For me, what was important was actually if there were any patterns, which of course, mental illness is one. So that was kind of what I was getting at, as opposed to details of particular cases. But thank you, that's very helpful to know the statistics.
Thanks, Nadia. Yes, we look for patterns and we act on the patterns. So we do thematic reviews all the time. We just can't report them here, but thank you.
Thank you very much. All right, thank you. Fine, thank you. So I think this is just a noting at Health and Wellbeing Board, isn't it? Yes, fine, thank you. All right, thanks very much. The next report for noting is the Better Care Fund. Catherine Wilmot, who is the Director of Adult Services, isn't here this evening. Are we just noting this report? But should we just say take as read, and if there are any questions?
Yes, thank you. It's apologies from both Catherine Wilmot and Sarah Bright. It's a joint report actually from Sue and myself, but it's on behalf of Sue and myself. But it is a retrospective report. It's already been submitted, so it speaks to work that's happened in Q3. It's a standard report. It comes here on a rolling basis, so it is to note, please, Chair.
Thank you. If there are any questions, should we have those emailed in and we can have a written response?
Yes.
Yeah, fine. Great, thank you. All right. Item 7, Sue and Toby, the joint forward plan for North West London update. Do you want to take us through that? Thank you.
So, thank you. I'm going to do a number of things and then sort of bring in Sue. So first of all, there's going to be a couple of apologies, then I'll sort of run you through what
That's fine. Do you want to just say who you are?
Okay, sorry, Toby Lambert. I'm the Executive Director of Strategy and Population Health for the ICB in North West London. So again, to a bit of apologies. Remind you of the statutory responsibilities, talk through how we prepared the plan. I'm not going to present all 90, whatever it is, slides which are in the plan, but I'll draw out a couple of the themes, and Sue will then link that to Hammersmith and Fulham, and then do a bit on next steps from here. So the apologies are probably twofold. So the first is I should have come and done this with you last year, but we had a bunch of elections, which you probably remember, which created some further periods which rather interfered with our ability to discuss this in public. The second apology is that we prepared this plan and indeed circulated it to you before the announcements on the capacity of various NHS organisations, which came through on Thursday last week. So I'm now in the slightly uncomfortable position of presenting you with a plan which made some assumptions on the capacity we would have over the next 5 years, which are now almost certainly not true. So we're going to have to work out what we do about that in a fairly short order. Statutory responsibility. So the statutory responsibility on health and wellbeing boards is to provide the integrated care board with your opinion on this plan, and in particular your opinion on whether the plan meets the needs of the residents of Hammersmith and Fulham as laid out in your joint strategic needs assessment. So it's not just for noting, there is actually a responsibility on the Health and Wellbeing Board to provide that opinion. On the how we prepared the plan, so this is the second of our 5-year plans. We're required to produce a 5-year plan every year. Seems a little bit bizarre to me, but that is what the statute says. Because we put quite a lot of effort in preparing our first one last year, we've had a relatively light touch update to last year's plan in what you've got before you this evening. So the 9 overarching themes from last year remain the same 9 overarching themes in this year. What we have done is try to be more specific on some of the actions and how we carry those out, and a little bit more ruthless in our prioritisation, given we have a finite amount of resource to affect some of the change, and now an even more finite amount of resource looking into future years. We do run, as part of our process, a broad town hall meeting to which we do invite all of our partners from across North West London, and that is the primary forum through which we've engaged on the plan before coming here. On the content of the plan, as I said, we've got the same 9 overarching themes from the previous year. They are there on. Should be about slide 16 of the pack, so I won't talk through them all. They've been reordered slightly. The important thing, though, however, is that you could get almost anything you wanted in healthcare probably underneath one of those 9 headings. So the real prioritisation happens in the ordering of what we do underneath those 9 priorities. And in essence, what we're trying to do is in the first year of the plan to bring in what we call our common core offer. So at the moment, the care you get in North West London can vary depending upon which borough you are in. Some of those differences are entirely warranted. So we have more homeless and rough sleepers in some boroughs than in others, but in others they are a product of historic patterns of investments and services. So some of our boroughs you get straight rehab and others you don't. And that's not right. So we've got a lot of focus on getting that core offer sorted in the first years. Now, no matter what how we do that core offer, we know our populations are not the same across our boroughs in North West London. Indeed, they're quite often more dramatically different within our boroughs than they are between our boroughs. And so the focus in sort of the years 2 and 3 is then how we tailor that core offer to the differing needs of our population, and in particular, how we engage with various sort of groups of that population to sort of build trust in the health service and to encourage people to come forward sort of as and when sort of necessary. Because a lot of the inequality which we see, some of it comes from the services which we offer and where the provision is, but some of it is also in the hesitation of some of our communities to engage sort of with services, either because we've not been very good at explaining how, or our track record of service delivery to them has not been very good, and hence our sort of trust can be quite low. Once we've done that, then we're into sort of how do we then, for those particular groups of population who, no matter how much you tailor the population, so how much you tailor the core offer, what we've got in that is not going to be sufficient. So there are a number of examples for that. So asylum seekers are a particularly sort of discrete population, sort of rough sleepers. There's a whole framework around Core 20, what we call Core 20+5, but it's then what are the additional services or different ways of offering service we need to offer over and above that. So that sort of really runs through all of the 9 sort of priorities as sort of cross-cutting themes. Right, this is where I now hand over to Sue to take us from sort of 9 lovely themes across North West London to what that actually means for Hammersmith and Fulham.
Thanks, Toby. So I'm Sue Rooston. I'm the Borough Director for Hammersmith and Fulham, so work for the ICB, but also one of the exec leads on the Health and Care Partnership. And on page 82 of the pack, there is a slide that references Hammersmith and Fulham and our priorities. So for those that have been members of the board for a while, I think you would have heard Caroline talk about last year, we had a refresh of our Health and Care Partnership priorities. Whereas an executive team, we all came together in September to think about how we take the partnership forward as part of Hammersmith and Fulham and link this into the joint forward plan priorities. So as Toby's already said, the 9 priorities have sort of stayed very similar. It's a refresh, but obviously our priorities within Hammersmith and Fulham and the partnership have shifted and evolved to take account of integrated neighbourhood teams and obviously the health inequalities work. So the way that we've framed it in H&F is health creation and the integration of services. And you'll see on this slide that sort of pertains to H&F, each of our INTs, so that's integrated neighbourhood teams, also called neighbourhood health now, just to add a bit more confusion, we change the names frequently. We've got a north integrated neighbourhood team, central and south. And one of the things as a partnership we agreed was that we would, each of those areas would take forward one of the priorities and lead on those priorities and then share the learning across so that then they would be borough-wide as we move forward. So the health creation community empowerment is being tackled by the North. So they're focusing on frailty, diabetes, and obviously reconfiguring some estate to allow people to work in a much more community way. Adult mental health, but also we've got children and young people as a crisis pathway that's going to happen across the borough. And then that's in central, and then in south, older people and dementia. So looking at integrated teams and how we reflect the work that we're doing as part of that. So the INTs will take forward the work. Caroline and the teams have been sort of identifying who will be part of those teams. I think originally there was very much focus that would be primary care led, but actually INTs and neighbourhood health is much bigger than that, and it needs all of the agencies and all of the partners working together to deliver. So essentially, we are using our partnership priority areas to support and deliver the requirements of the joint forward plan, recognising that there is quite significant deprivation and health inequality in Hammersmith, and focusing our efforts around those areas so that we can then look at the benefits and measure the change as we go through. I think I'll probably leave it there, but I don't know, Toby, are you doing next steps?
Yeah, so I'm going to do two things. So one is to pull that back up to the Northwest London level a little bit. So Sue's talked a lot about sort of integrated neighbourhood teams. You can see our priority one is establishing those integrated sort of neighbourhood teams. We are doing that in a bit of a sequence as opposed to which sorts of sort of residents we are focusing on. And in sort of the first year, we're focusing on sort of older adults, so it's picked up the frailty and sort of dementia points, which are also back in the Hammersmith and Fulham priorities, but also on sort of how we strengthen our sort of model for sort of more sort of complex children, which sort of references back to things like the children and young people's sort of crisis pathways. So what we've generally found is that though we use slightly different language in the 9, they pick up about 80 to 90% of what any of our individual boroughs are doing, or what any of our individual boroughs want to take forward. And hence we do get some sort of economy of scale by trying to work out the answers to some of those difficult problems once across Northwest London, and then tailoring those answers to the particular circumstances of our individual boroughs. So let me move on to sort of next steps. So as said, we are coming to all of the health and wellbeing boards for sort of feedback and sort of on the plan. Hammersmith and Fulham is the last of the health and wellbeing boards. So I'm here to solicit feedback from you this evening, in particular that sort of opinion on whether the plan meets the needs of your residents. Once we have that, we will put it all together, go back through the sort of the draft of the plan with a sort of view to publishing in fairly short order.
Thank you very much. I think there are probably going to be quite a few questions on this item. The first one is probably, obviously, given all the recent announcements, how significantly do you think everything is going to change, and how different is this going to look once you've had a bit more time to think this all through?
So the answer, so there's probably two answers to that. So the first is, at this point in time, we still do not have very much clarity on what the announcements means beyond the headlines. And the headlines being 50% out of NHS England and the Department of Health, and the abolition of NHS England, 50% out of the ICBs, 50% out of provider collaboratives and what we call operational delivery networks, which are things like critical care networks and the cardiac networks, and then sort of 50% out of the corporate growth in our trust, which is basically their non-frontline staff. I find it very hard to believe that that is not going to severely constrain our ability to sort of transact or support change and transformation in services. But at this point in time, we haven't done the work to translate that into what exactly it's going to be. But the numbers speak to themselves, and it can't be anything other than significant.
Thank you, because it feels slightly moot for us to feed in on a plan that is possibly going to be completely redundant within a few weeks, and also alarming, obviously, when we're thinking about things like cancer testing rates that will need innovation and rethinking, given how low some of our testing rates are compared to the rest of the UK, which will almost certainly need innovation. I'm thinking a bit differently. If there's no capacity to do that, that all feels quite alarming. It does, as I say, feel slightly hard to think of more questions, so we'll very much like to stay in contact about this book. Councillor Perez, have you got anything that you'd like to ask?
Thank you, Chair, and thank you, Toby, and thank you, Sue. And I know the situation and the uncertainties at the moment, but do you foresee that some of these priorities, the 9 priorities that you have alluded to, will some of these priorities be deprioritized, or would they have to be revisited? Are there particular priorities that you think will be affected?
So, well, and the answer to that is yes, but I can't give you any specifics on sort of which priorities and how. We were in any event expecting to revisit the priorities over the course of the year with the imminent publication of the NHS's 10-year plan. So it's still I understand, sort of due for May. So we were always expecting to revisit them. So at the moment, our overwhelming priority is on the integrated neighbourhood teams, because that is the best vehicle which we have for engaging with our residents, trying to move care closer to home, so integrating better with the services which our various partners, including sort of local authorities, but also voluntary sector providers and so on. So And at the moment, I would say that is the one sort of North Star which we intend to cling to. But when the 10-year plan is published, I may discover that we're being set a different priority.
Dr. Kavanagh.
I just say Toby and I and others here have been in this for a long time, 20 years more, and we've seen restructures happen several times. The themes around inequality of access to healthcare, difficulties with screening, problems with childhood obesity, some of the themes we've highlighted here remain the same. And yes, if there's innovative technology that will help us to facilitate access, to change some population's views on things like screening, fantastic, happy to engage with those, but the problems will remain the same. And so I think these strategic documents actually do help. And if we look back at them, they have provided pathways for us to evolve healthcare provision with the resources we have. And we've seen that in Hammersmith and Fulham over 20 years, from small individual GP practices, moving now to PCNs, which are delivering far more efficiently, I think, than when I came into general practice. And I think neighbourhood teams will offer another step forward to address these themes. So yes, there'll be a lot of sound and fury around the reorganisation and innovation, but the problems for our population remain the same.
Thank you. That does slightly beg the question, why haven't we moved on in 20 years and why are those issues still the same across the board? And I mean, I hear what you say, and I think some of that is specific to a North West London population, but it's frustrating when there are some very poor metrics. I think at the last ICB we touched on cervical cancer and don't want to go into that all again, but the fact the testing rates are so low, and yet, as I have said to you before, that Imperial within the borough, there is someone who's invented an at-home screening test. That innovation is right there, and it would just be great if we could find a way to access it and not be caught up in a redesign. Fine, well, thank you. It is good to see these, and thank you. It's helpful insight that it is the same issues, and hopefully we will find a way to deal with some of the more wicked ones. Any other questions or comments on this? Sue.
Thanks. It was also just to, I guess, reiterate what Toby was saying. So one of the things that certainly we've been working on as a partnership across the borough is how do we deliver this sort of with everybody involved, so that obviously there will be significant change. There will be significant change in the providers, and including the ICB as the commissioning organisation. But I think let's not lose the priorities that we've got on page 82, because actually they're meaningful for everybody, and in terms of how we deliver that as a system. So I think, yes, there will be less people around, I'm sure, but we've got to hold on to the fact that we want to do this for our residents. Thanks.
Thank you. Thank you. All right. Anything else? Were we noting? Fine. Thank you. Okay. Well, that takes us to Health Watch update. So over to you guys. Have you got a presentation or? Yeah. Lovely.
Well, I'll speak while you look for it. Thank you, Chair. I am Colleen Duffy. I'm the area manager for Health Watch. I'm normally represented here by our chair of our local committee, Nadia Taylor, and I am joined by my esteemed colleague, Ruchi Wadwa, who is going to present the majority of the presentation. I know that in the pack there is, I think it's 50-something pages we wrote for the report, but nobody's going to speak through that. We've got a presentation that we're going to speak through, and if anyone has any questions after reading the report in more detail, please feel free to raise them now, or if they're absent, send them through to me.
Good evening, everyone. My name is Ruchi. I'm the Project and Engagement Officer for Hammersmith, Health Watch Hammersmith and Fulham. So just to go through our impact this year, I'm sure everybody here knows what Health Watch is, but just to reiterate, we are an independent voice for our patients who use NHS and publicly funded health and care services. How we do this by 4 main ways. The first is, next slide. The Patient Experience Program. This is our flagship program under which we get around 1,200 views per quarter. Then we do enter and view visits. This is our statutory power, and we do around 4 visits every sort of financial year. We kind of pair this up with 2 deep dive research projects every year, and we do some information and signposting and other engagement and outreach activities. So I'll just talk about our impact in a nutshell. So we have over the course of, so we got this contract in 2021, and over the course of last 4 or 5 years, we have done a lot of work. So we want to highlight the main recommendations that we made and what was actually picked up. So if we talk about our enter and view project, so we recently in 24-25, we did the enter and view for hospitals, outpatient services, and Chelsea and Westminster Hospital, we made around 6 recommendations, all of which were picked up. We still have to go and revisit to see how they are being implemented, but they have sort of started work around this. For our Back on Track program, we made 4 recommendations. All of them were implemented. Same is the case with our GP practice enter and view, where we looked at the access to the GP practices post-COVID. We made around 7 recommendations. All of them were fully implemented. For care homework, we made around 31 recommendations, out of which 14 were fully recommended, sort of adapted, while 5 were partially accepted and 2 are in progress. Rest of them are still under review. Same is the case with our community pharmacy. We made 10 recommendations, out of which 4 of them were fully sort of implemented, 3 partially implemented, and 2 are in progress. If we talk about our deep dive research projects, over the course of last 5 years, we have done around 9 projects. Like in 2021, we did the CARES project. We had around 6 recommendations. Then we followed that up with young people's mental health project during COVID-19 pandemic. We did sort of a collaborative project looking at the experience of people with the London ambulance service. Then this year we have done, last year we looked at the views of people around vaccinations and cost of living, sort of what were their experiences and what were the struggles they were facing due to cost of living crisis. We did some work around the maternity experiences of ethnic minority groups. So we make we have made loads of recommendations through these projects. But the thing is, for our enter and view, it's more of a statutory duty. So whatever recommendations we make, it is very easy to sort of trace if they were implemented, and we sort of put more resources to that because they are being followed up by Healthwatch England and CQC. But for our projects, that is not the case because we don't have that much resources to go and trace if every recommendation was ultimately implemented or not. So usually our sort of project work kind of helps to shape the strategies, or sort of just to look into what's actually going on in the borough, or if there is sort of area which needs more sort of data, or where there is a research gap, we just try to address that through this. Then in last 5 years, next slide please. Through our engagement events and outreach activities, we have reached out to a lot of people in the borough that shape the local health services. We have attended a total of 527 meetings and engagements, and this has resulted in us talking to around 13,500 people. And this is excluding the patient experience program, where we collect 1,200 reviews every quarter. As far as volunteer support is concerned, because we are a very small team, we do need volunteers. They are the ones who actually help us get through this. Since 2021, we have had around 167 volunteers who have given us 5,021 hours, which amounts to like 743 work days. And our aim is not only just sort of getting help from them, but we also aim to upskill them and sort of make them ready to go and work, make them ready for employment essentially. And a lot of them have gone to like work in health sector. Some of them have sort of started working in places like Citizens Advice. So it's actually a quite good relationship that we have developed. Then I'll just go on to different recommendations that we have made in 24-25. If I talk about the primary care services, next slide. So because patient experience program is ongoing process, and so the recommendations that we have made since 2021 are no different from the ones that everybody already knows since 2012. I think the issues are all the same. Because I think the reason for this is the issues are actually part of a much wider, much bigger system instead of something which is local. So from our end, what we do is we try to sort of cater the patient experience program so that we can do more than just sort of saying the same things every year. For example, through our patient experience program, we have made a lot of links with managers and the local practices. So if we see or observe any pattern that we feel like is specific to a practice, we kind of highlight it with them and we give them time to sort of address that with us. And that's how we sort of kind of cater to everybody. But yeah, all these recommendations are pretty much same, whether it comes to GP practice or hospital service recommendations or the pharmacy or the dental services. And so I'll quickly move on from this. So for our enter and view program this year, we looked at the next. Yeah. So we looked at the outpatient services in hospitals used by Hammersmith and Fulham residents. So we visited Charing Cross Hospital, Hammersmith Hospital, and Chelsea and Westminster Hospital to evaluate the outpatient department experience of the residents and the staff. Through this work, we talked to 52 patients and around 20 staff members across the 3 hospitals. And for our recommendations, next slide. We made recommendations around improving signage and navigation issues, appointment communication challenges, waiting time transparency, complaints procedure awareness, accessibility and disabled patient support, and staff well-being and support. So out of these, Chelsea and Westminster Hospital has very kindly sort of given us a formal response. So they have sort of implemented the recommendations we have made. They have developed a new signage plan with improved wayfinding scheduled for implementation by late 2024. So we are yet to go in and see how it is going on. And they are also working with the internal team to align the appointment communications with the hospital wayfinding. They have also expanded pre-appointment reminder calls, and they are reviewing their administrative process to reduce scheduling errors. Apart from this, they have now information sheets available in different languages, and they are displayed in all the outpatient departments. And in addition to this, outpatient teams now are holding monthly meetings with their staff to see if there are any concerns or if there is any area they can provide support in. Whereas for the other hospitals, Charing Cross and Hammersmith Hospital, we are yet to get a formal response, and we are working on that. So for our projects, just next slide. Next. Yeah. So for our suicide prevention work, as it was discussed during the suicide prevention strategy, that almost 50% of the cases are of the people who have some kind of like mental illness. And that was one of the reasons why we wanted to do this. So we already do our mental health inpatient work, which has been commissioned to us since 2022 by the Northwest London Mental Health Board. And just as a part of that, we went into the mental health inpatient units and we talked to inpatients and the other contacts that we have through this about their experience with the services that offer suicide ideation help. And based on that, we have made some recommendations. This is still ongoing work. We are still in process of sort of analyzing and finalizing the data, but this is our preliminary recommendations. And these are to expand peer-led support groups, to raise awareness through campaigns using real-life recovery stories, to encourage, to address the misconceptions and to encourage people to seek support and help. Then we have also recommended around family education workshops, providing training for the family members, to expand the crisis helplines to sort of include more of text and chat support, especially for people who are not very comfortable voicing out their concerns. Additionally, we have recommended that there is fast tracking of mental health referrals so that people who are actually in need of help, they can actually receive it. Then we have also advocated to set up support groups in community centers, faith-based organizations, so that people are able to find help in more of a community setting area, so that this is more approachable for them. And again, like I said, this is an ongoing work, and we will have more on this maybe by the next Health and Wellbeing Board. Next is just the engagement work, just to again reiterate the engagement that we have done this year. Next. Mental health and suicide prevention has been a big focus for us this year. So since 2022, we are commissioned to do the mental health inpatient work. And just using that, we did some of our suicide prevention work around that. In addition to this, since September of 2024, we have done a number of community events around that promote mental health awareness, including suicide prevention initiatives. And we did them collaboratively with charities like Mind, The Listening Place, Papyrus. And we have also offered vital training and mindfulness coaching for additional support to local people. And the outcomes of this have been that this has through our mental health inpatient work, we have advocated for structural ward orientation, treatment plans, community building activities to improve the patient experience. We have recommended improvements in safety, facilities, activities, meal diversity, and discharge planning. We have also proposed peer-led support groups, which I have already discussed, family education workshops, crisis intervention services, and increased drop-in mental health support. And we have also trained all our staff in suicide awareness, which has enabled us to engage with local people, more than 100 local people, and support them, or collect feedback, and sort of signpost them to whatever sort of help they need. And we have also promoted mental health awareness and open conversations on suicide prevention, guiding people to like appropriate services. And the impact of this have been that our efforts have helped to shape the Northwest London suicide prevention strategies. We have influenced patient care improvements. We have strengthened mental health support networks and crisis intervention efforts. And we have ensured those in need access vital resources in a timely manner. Next. So we have continued our maternity health inequalities engagement work from last year. So we did a project looking into the maternity experiences of women in Northwest London, and we focused on ethnic minority groups in Hammersmith and Fulham. As a part of this sort of engagement, we were able to get a spot on the advisory board of co-production work that is happening in Imperial, the Black Maternity Co-Production Project. And we are currently sort of feeding back whatever we are hearing from our experience, and we're just acting as a bridge between the work they are doing and between our statutory powers in, say, Health and Wellbeing Board and our presence at other meetings. And what this has resulted in is improved maternity care for ethnic minorities through continuous feedback. And we have established peer support groups, boosting community involvement in co-production efforts. Next. Since we got this project in 2021, we have done a lot of work around vaccine, a lot of work to address the vaccine hesitancy. In 2022-23, we did a social media campaign on monkeypox and polio. Then in 23-24, we did a full-on project to see what were the experiences of people or what were the issues that were sort of pulling them back from getting vaccinated. And this year we are continuing this by talking to mothers and older people, trying to find out what are their experiences with vaccines. So we are particularly focused on childhood vaccinations, particularly MMR, and for older people, we are particularly focusing on flu and COVID vaccinations. And we are just in phase of collecting data for this particular project. And yeah, it's in a very, and once the data collection is done, we'll be able to have sort of more on this. Thank you. I know that was a lot, but if there are any questions.
Thank you. That was very comprehensive and really interesting to hear about the work that you're doing. I just have a couple of questions. I'm sure my colleagues will have questions as well. Do you have a link to PALS to get feedback from them, kind of common themes that might be coming up in hospitals that people are raising issues with?
Normally we don't, because we're supposed to be independent. So we do speak to them and to advocacy about sort of the most common complaints that we get coming through. But we don't, or we will share with them themes and trends. We won't discuss specific cases with them.
Oh, sorry. Sorry, I mean like a thematic, if anything's coming up thematically.
Yeah, we do that.
Yeah, thank you. And then the vaccine hesitancy work sounds really interesting. Would love to be posted. I think there's lots of work going on across the council about that. So that's wonderful to hear. Thank you. Councillor Perez.
Yes, thank you very much, and thank you for that thorough presentation. So I was looking at one of the slides, and you were talking about, well, in relation to GP access services, how one of the recommendations was to expand online booking options. So I mean, it's good to hear that there's an appetite for that. But did you also find that maybe some of the patients that you spoke to, did they refer to any concerns around accessibility when it comes to digital inclusion? Is that an area of concern or not? And if we're moving towards using more and more technology, what's the recommendation in terms of mitigating accessibility?
In terms of digital exclusion, it is an issue, and it's not just it doesn't just always come down to preference, although that does exist. But there's, it's not an issue. Just people always think of sort of age. It's sort of older people, but there's a lot of physical disabilities and even some mental health conditions that make people very reluctant to constantly be engaging online and just prefer to have a person. It is something that goes on. We've been on the digital exclusion board. Well, I am on the one in Ealing that gets fed up to sort of the work that happens at North West London level. I haven't done as much in this borough, but there is work going on in here. We did link up with Age UK a couple of years ago and did do sort of work with them around people that were digitally excluded for various reasons. There was, poverty, that, people didn't have things, and we'd linked up with some charities to try and get the devices out to them. There was some where, it was just a case of they just needed classes on sort of how to use things more technically. And we've linked up, and I know we've done work with sort of Sue and things with within the practices. We've started going to the PPGs and doing some sort of digital classes there around that. But there will always be it can never be completely online realistically, because it would mean that there are patients that are unable to get in contact with their GP. But there are some great work going into the apps that's been developed.
Thank you, and a good moment to plug the fact that at Macbeth Centre we have got lots of free classes on digital inclusion and learning how computers work. So if anyone would like those, they are there. Good to read your bit about working with Age UK as well on training. I think important question, and you're right to highlight that it is so much more than just people who might be older. There are all sorts of reasons as to why people may feel less comfortable using tech. Thank you. Was it Dr. Kavanagh? Thank you.
Yes, I just thought it might be helpful to just inform the committee that we recognise this risk of digital exclusion. We are on this cleft stick where we are being asked by the public and encouraged by the Department of Health to increase access to general practice through digital channels. And for many of our population, that's a very convenient and a really popular way of getting quick access to solutions to their problems. But we've also commissioned, through the single offer in general practice across North West London, proactive lines of activity for general practice to reach out to people with learning difficulties, people with mental health problems. And particularly in this borough, we have a local offer around frailty and recognising, diagnosing frailty, and then encouraging our medical teams to proactively care plan with the patients and their families. So it'll never be perfect, but what we try and do is address through commissioning obvious cohorts in the population that are excluded by the onrush of digital access.
Thank you very much for those answers, and it's great to hear the solutions that are in place as well to mitigate some of those concerns. I noted in another slide that you spoke about suicide prevention, and you alluded some of the recommendations that you had was fast-track mental health referrals. So people are now waiting for assessments for weeks rather than assess promptly, and also an increase in dropping mental health services. So those are some of the recommendations that you have. And I wanted to ask Dr. Lang as well if some of this feedback is also incorporated, and does it feed into the more strategic work that you presented earlier as well, in terms of some of the recommendations that have been put forward. Thank you.
Thanks, Councillor Pears. I've just seen the report, so we'll take that forward with colleagues from Healthwatch. So thank you.
Thank you. Any other questions? Perfect. All right. Thank you very much. Nadia.
Maybe just a very brief sort of taking advantage of Dr. Kavanagh being here. Can I just say, from a patient's perspective, I know there is a huge drive towards the digital agenda, but I did just want to highlight, or would like to highlight, the fact that it seems patients are, and I'm actually presenting here views of carers as well. I chair another organisation which supports unpaid carers in 3 London boroughs, including Hammersmith and Fulham, and that is very much feedback that comes from them as well. There does seem to be a greater number of appointments offered if one requests one via patches. Now, the digital exclusion or access is actually a huge issue. I think we tend to downplay it, I have to say, representing 2 organisations, both of which actively engage with the community and seek feedback and receive feedback in great numbers. It's quite important to know this. So I think we do downplay the disadvantages of that digital agenda, because many people are excluded for all manner of reasons. It's not just equipment, it's not just skill about knowing how to use the equipment. It's psychological. It's all manner of problems. But I just wanted to kind of make a plea, if you like, collectively from the feedback that I have had, whether it's possible for GP practices to offer the same number, or at least closer numbers in appointments when one rings on the phone versus what one can achieve when you request an appointment on patches. I know from personal experience as well, and Dr. Kavanagh knows, I belong to his surgery, it is very much the case that you are directed to patches, and the feedback from the reception staff always is you have more of a chance to get an appointment, even for today, because there's more appointments available online. But not everybody can access those. That's the point I'm trying to make, and I would like that kind of be sort of seriously taken on board, because it is downplayed.
Thank you. And I think that kind of speaks to a slightly patchwork approach, because that's not the approach at my surgery, for example, where it's completely different, which is also confusing if you're a patient moving in between various patients. But I think quite clear plea there to have both the online and phone options. Thank you. Great, thank you very much. Item number 9, work programme. I'm going to suggest that we leave that until we've got slightly more fuller complement of people in the room, given we're somewhat skeleton this evening, which just takes me to dates of future meetings, which is the 23rd of June, 10th of September, 3rd of December, 18th of March next year, and 22nd of June next year, the full list of them. Thank you. I think that is everything. So thank you very much, everyone, for coming. I think unless there's any OOB, we'll bring the meeting to a close there. Thank you so much for your time this evening.